Production support for this episode of In Focus is provided by Hoosier Energy, providing electricity to Central and Southern Indiana electric cooperatives and their member customers. Information at HEPN.com. And by WTIU members. Thank you.
Following the re-election of President Barack Obama and the retention of a Democratic majority in the United States Senate, the repeal of the Affordable Care Act is unlikely. That means the state of Indiana has to decide whether it will set up its own health care exchange or allow the federal government to set one up for it. We'll talk about the consequences the decision will have on health care providers and on Hoosiers as we put the implementation of health care reform in focus. And thanks for joining us for this edition of In Focus. I'm Stan Jastrzebski. The Affordable Care Act requires states to decide whether to set up their own health care exchanges or let the federal government do it. It also gives states the option to expand their Medicaid coverage. As WTIU's Gretchen Frazee reports, Indiana has so far taken few steps to implement that federal law.
States must consider several factors when deciding how to implement the Affordable Care Act. The most pressing issue is setting up a health care exchange. Seema Verma is the state's health care reform lead. She says exchanges are basically online databases where patients would be able to shop for the best health insurance.
Think of it as an Expedia or an Orbitz to buy health insurance. So it's a place that you can go where you can compare cost and quality and then make your purchasing decision.
States must declare this month if they want to set up their own exchange. If they want to partner with the federal government, they must decide that by February, or else the federal government will step in. Prior to his election, Governor-elect Mike Pence said he did not want to set up an exchange.
I believe we should not. It's a deeply flawed bureaucracy. And my competitor's idea about a hybrid exchange, quite frankly, my experience is the federal government usually partners with states the way an alligator partners with a duck.
We need to move on. Thank you.
We won't be winners in the hybrid, we'll be losers.
And after the election, Pence has maintained that view. Besides the exchange, there's also the Medicaid expansion. Indiana hired Milliman Consulting to estimate how much Medicaid expansion would cost. Its report said the Medicaid expansion could cost Indiana $1.7 billion over 7 years if it extends coverage to anyone whose income is at or below the federal poverty limit. But Milliman Consulting actuary Robert Damler says if the state does not expand its offerings, costs would still go up about $600 million because of changes the Affordable Care Act made to Medicaid on a federal level.
There will be promotion of this by the, we anticipate by the federal government and health insurance exchanges and by advocacy groups. Individuals will hear about the need to have health insurance and the mandate to have health insurance. And while that mandate may or may not apply to them, they will present themselves to identify if they're eligible or not.
The Supreme Court decision made the expansion of Medicaid optional, and there's no set timeline for states to expand Medicaid. But there may be benefits to implementing it earlier rather than later.
The first 3 years are 100% federally matched. However, that is actually not defined as the first 3 years of when the state decides to expand, but actually the first 3 years, calendar year 2014, calendar year 15, and calendar year 16.
So if states want to expand, they will not receive as much federal funding as they would have if they expanded right away. Dr. Rob Stone is the founder of Hoosiers for a Common Sense Healthcare Plan. He says even though some doctors may not want to accept more Medicaid patients, it's too good of a deal for the state to pass up.
It's still been clearly proven to be better than no coverage at all. It helps people get better care. It helps people be healthier. It improves the health of our workforce in Indiana. It has much broader economic implications than just the fact that it would be federal money coming into the state that we wouldn't get otherwise.
Indiana is considering alternatives. It has its own program called the Healthy Indiana Plan that provides additional subsidies to low-income Hoosiers. However, they also have to pay into the plan. That means it tends to cost the state less money than traditional Medicaid. Indiana has appealed to the federal government to ask if an expanded state plan would qualify for the same federal assistance as Medicaid expansion. The federal government has not yet provided an answer.
And we're joined in studio tonight by Nancy Jewell, the president of the Indiana Minority Health Coalition. Also, Mark Moore, the CEO of IU Health Bloomington Hospital, and Heather McCabe, an assistant professor at the IU School of Social Work and an adjunct professor at the IU McKinney School of Law in Indianapolis. Thanks to all of you for being here tonight. Nancy, let me start with you with kind of a general question. What is your sense of, first of all, how many people are uninsured in the state of Indiana? And are there specific groups of people you're aware of that have large swaths of that group of people who do not have any insurance that will then be required to buy it once the Affordable Care Act takes full effect?
Well, actually, the numbers are not accurate because you have some populations that are just not being counted because they're new immigrants into the state, so they don't have access to health insurance. But there's hundreds of thousands of Hoosiers that do not have access to health insurance, as well as do not have access even to a community health clinic if there's not one in the county.
Do you get the sense we're talking about, 1 in 10, 1 in 12? Do you have any guess about what percent we're talking about?
If I would guess, I would say probably about 1 in 12.
Heather, let me go to you for a second. I've talked with the mayors of Greencastle and Terre Haute in the last couple of weeks, both of whom were involved in healthcare before they became mayors of their respective cities. And one thing they keep telling me is there are people who are currently falling through the cracks, whole groups of people that are not getting the coverage and the attention that they need. What is your sense about those groups of people? Who are they? Who gets helped? Depending on what Indiana decides or decides not to do?
Well, we currently have a system where if you want to get help through the Medicaid program, you have to both qualify financially and categorically, which means you have to both have financial indicators and you have to have a disability or some other pregnancy, be a pregnant woman, be a child. There's categories and there's financial criteria. If, in fact, we would choose to go to a expanded Medicaid program, those categories would go away, and we would only have the financial criteria. Now, Indiana has bridged the gap somewhat through their Healthy Indiana plan, but we know that that has limited slots and has a fairly significant wait list. So those same folks who might be served under the Healthy Indiana plan might also be caught if, in fact, Indiana would choose to do some kind of Medicaid expansion at this point.
Is it still up in the air? Do the three of you get the sense that Indiana's not quite sure what it's going, lawmakers aren't quite sure what they're going to do with respect to expanding Medicaid eligibility or not?
Oh, yeah. Yeah, definitely. Actually, they don't know what they're going to do trying to implement the Affordable Care Act. But just to tie into her answer, also you have over 40 counties here in Indiana that are medically underserved areas, healthcare professional shortage areas, so that limits people to having access to services, and those folks are falling through the crack.
Mark, you're shaking your head. First, how do you determine whether someone is underserved and whether they might need to be paid more attention to?
Well, the first thing I'd say, Stan, though, is that the hospital industry has been very supportive in general of the Affordable Care Act because of the expansion of access. That we know if people have health insurance, they're more likely to get the primary care relationship that they need with a physician or a nurse practitioner, and that leads you into more preventive care than just reactive care and ending up in our emergency departments as a result of that lack of access. So in general, the industry has been very favorable, but there was a trade-off, and that trade-off was the acceptance of future Medicare and some Medicaid cuts in exchange for an expansion of the eligibility of the Medicaid. So part of the concern here in Indiana is the double whammy, that we get the cuts, but we don't get the expansion and the access improvement for our populace. So back to your original question, I think there's always a screening process we try to use to see if there's eligibility for some form of insurance, whether it be Medicaid, Healthy Indiana plan, just something that gets that relationship and pulls down the barrier to the access issue I'm talking about.
Some years ago, well before we'd even started talking about the Affordable Care Act, I had a friend of mine who was an EMT say to me, one of the problems with healthcare in America is we are in the business of making people better not making them well. You know, so that we are always fixing problems rather than anticipating them. Do you see that the changes that the Affordable Care Act is designed to make are going to change that problem within the system, that sort of structural issue?
Yeah, if you let me digress just for a quick second. There are trends that have been happening in healthcare that are related to what you're talking about, that we generally see kind of a slow but sure movement away from being volume-oriented. In other words, we're rewarded for how many things we do, how many admissions, how many tests, to also being accountable for the outcomes, both clinical, patient satisfaction, and ultimately the financial outcomes. These trends have been put in place and are already starting to move, both with federal reimbursement as well as private insurers. So in one sense, whether it was a Republican or Democrat in the White House, we still saw these trends continuing down the road. But now that we know the results of the election, I think we're more assured that the Affordable Care Act is going to continue to move forward in some form or fashion.
You were shaking your head a second ago, Nancy.
Yeah, because also in the Affordable Care Act, it discussed preventive health services, which a lot of times our system is not supportive of as far as federal dollars. It usually goes toward treatment. Women health, preventive health services has really expanded within the Affordable Care Act. If all of that if all of that is mandatory, and Indiana selects to incorporate that in their essential health benefits.
I'd be interested to get a thought from all three of you, and Heather, I'll start with you. I was interested to note this week that when House Speaker Brian Bosman named his next chief of the House Ways and Means Committee, it was a doctor, Tim Brown from Crawfordsville. I'd like to know what each of you thinks about the fact that a physician is going to be leading the money side of the House of Representatives in Indiana for at least this budget cycle that's going to begin in January, and how that affects how the state is going to look at the Affordable Care Act.
From my perspective, I think that it'll bring some experience in the area to that particular position, and someone who has some knowledge about healthcare and healthcare financing. I will say that not having had interaction with him and knowing him specifically, I'm not sure exactly how that will play out, but I do believe that it will be important to have someone who has some knowledge of healthcare funding, because I do think that the healthcare and healthcare access and all of the components of the Affordable Care Act are going to be a large portion of the next budget, and as we move forward, what we're going to do legislatively.
Mark, your thoughts?
I would just generally support the fact that if you've got someone familiar with healthcare, intimately trained in that profession, they should certainly appreciate primary care, the access that patients need, and more about preventive care for the long-term benefit of our society.
We have dealt with them for years, and I know that he sat on the health committee, and for years he's always supported health initiatives. So maybe that's because he's a doctor and he sees the benefit of it, or maybe that's just because he understands that you have to do preventive health and other things so that you don't have to pay more down the road.
Let's start with you, Nancy, on this next question and go back down. Let's get at maybe one of the core issues, which is Governor-elect Pence has said he's going to let the federal government run the Affordable Care Act's implementation in Indiana as far as it goes. He does not want to set up a state exchange. I'd like each of your thoughts on better to have a state exchange or better to let the federal government, which has been planning for this for years and years and years, whereas Indiana has been reluctant to plan at all based on politics, really. Better to have a state exchange or the federal exchange running things in Indiana?
Well, it depends on what you have as benefits in the exchange. In some states, it would be better to have the state run it. But I'm not sure in this situation how that would impact on people being able to access and getting the support they need.
Okay. Mark, your thoughts?
I'm generally always in favor of states' rights, so to speak, and in the sense that I think our understanding of our marketplace, our issues involving providers and key legislators would be more successful in meeting our needs.
Heather?
I think I would say that the hospital industry and the insurance industry has tended to also support the states running the exchanges because of the very things that Mark pointed out, that states can be more responsive to the specific needs. There may be some who would say that a federal exchange, a federally based program would be better because it provides more continuity and a more centralized focus. But again, I think industry has certainly been very supportive of a state exchange, and for those who tend to see more states' rights, I would think a state-based exchange would also be something wise. One of the things to note is even if Indiana doesn't do a state-run exchange at this moment, as I understand it, it has not been precluded that we might do some hybrid. Certainly in the debates, there was some concern about a hybrid exchange, but as I understand lately, that door hasn't been completely shut to do a hybrid exchange. Also, if we choose not to do a state-based exchange this year, that does not preclude us from next year applying to do a state-based exchange if we find that that would be better suited to Indiana's needs.
What are some Indiana-specific issues that you think need to be paid more attention to than they might be in Illinois or Kentucky or Ohio? Are there specific conditions, specific groups of people, factors about a lot of rural geography in Indiana that you think, you know, the state would be more inclined to pay special attention to that the federal government might overlook?
Well, we certainly have, if you look at our public health numbers, if you look at the way that we do preventive health, our obesity rates, our smoking rates, most of those public health indicators, Indiana does not fare terribly well comparatively to other states. And so as both of you have mentioned, that prevention piece as something that if Indiana really wants to be fiscally responsible as it moves forward in healthcare, they're going to have to pay attention to the prevention components. And we also are going to have to ensure that we do have the workforce available to have this, you've, I think, mentioned, Mark, a couple of times the primary care relationship. We need to look at, do we have a workforce trained to provide the primary care that's needed? And if not, how will we move forward in that? And Indiana can really look at that.
See, I'm very supportive of us, again, moving, like I said, from a value-based industry, from a volume-based industry to a value-based industry that places us more at risk as providers for population health, for really trying to take care of patients in terms of their totality, because it realigns the incentives. The incentives are today to take care of disease. Give us the incentives to take care of health.
Right. Absolutely.
Mark, let me ask you, from the point of view of an individual hospital or an individual healthcare provider, what differences do you think they will see by, say, the middle of 2014 when this is fully implemented? How is their business, how is their day-to-day work going to change, if at all?
Well, by 2014, I'm not sure there'll be dramatic change other than the beginning of increasing our risk. For instance, in Medicare reimbursement, we'll be close to 10% at risk for those clinical outcomes and patient satisfaction.
What do you mean when you say at risk in this case?
In other words, they have certain benchmarks. The federal government will set certain benchmarks for the attainment of certain clinical outcomes, and then also for percentage of patients who respond favorably, that you've had excellent care in your institution, et cetera. And if you fall below those benchmarks, there's a certain element of your reimbursement, in this case up to 10%, that will be at risk of losing that payment.
Yeah, we've talked to a couple of hospitals. I talked to someone at Union Hospital a few weeks ago who said they were going to lose potentially hundreds of thousands of dollars because they had too many readmissions based on, you know, poor health outcomes within 30 days of being released from the hospital. And so that's certainly something that I think a lot of hospitals are concerned about, is losing money in this fashion, right?
And that's an example of an outcome that I'm talking about, readmission rate.
Nancy, let me ask you first on this question, and we'll go back down the panel real quick. Even if the state goes the federal route and it lets the federal government do this, and by all accounts that will cost less, maybe as much as $1 billion less than implementing it statewide, they've said. Does the state need to allocate, nonetheless, more money to its health care coverage, to covering Hoosiers and making sure that they are seeing better health outcomes, maybe even if that means dipping into what is at the moment about a $2 billion budget surplus? Does the state of Indiana need to devote more money to health care broadly?
Oh yeah, I think they do. I think they need to provide more dollars for preventive health services. Right now they're looking at dismantling the at-risk insurance pool at the end of this year, which means it might not go away. Those people have to be placed someplace, and it might be the state that have to fund that.
Can you explain that for just a second?
The at-risk health insurance pool actually was around before HIP, and it was for people who might have been denied through Anthem for insurance coverage, and so they buy into the insurance. It's a little costly, but it's cheaper than buying into it if you were going with Anthem or one of the other insurance providers. So they're looking at dismantling that going into the next year, and like I said, they'll have to put them someplace, but where they're going to put them, I don't know. And maybe they're going to use state dollars to try to supplement something else to insure those folks.
Mark, more money spent on healthcare in Indiana from the state level?
I think if it's done correctly, it's, as Dr. Stone on the earlier clip said, it's an investment in the quality of life and ultimately the economic well-being of the state. That I'm back to primary care again, that if patients and families have some form of relationship, they can be their medical home, help them, guide them through the medical delivery system and start to place some incentives on their health and well-being, that ultimately behooves the state of Indiana to make more investment.
Heather, your thoughts?
I'm going to agree with my colleagues here. I think that this investment, again, when we look at the public health numbers for Indiana, our obesity rate, our smoking rate, we're not doing well. And it costs us a lot in the end to take care of the problems that come down the path because we have not put the money into prevention. It is a lot of money. When we talk about the raw dollars and we're talking about millions and billions of dollars, it is a scary proposition. But I think that the concern is, what if we don't invest those dollars? Particularly when we have hospitals, our disproportionate share hospitals, we've already asked them to make some changes because we intended to, through the Affordable Care Act, cover more people through these Medicaid expansions. If we don't invest in that, I do have some concerns for what that will mean for our hospitals who both have made these concessions for that and still now have to care for people who don't have coverage through other means. And the pre-existing condition component that you're speaking of earlier, in terms of the people who were covered by the comprehensive health insurance, people who could not get health coverage elsewhere, part of the Affordable Care Act is that they will not be able to be denied for pre-existing conditions. So these generally are folks who cost a lot to care for. And we need to be thinking of, as a state, what are we going to do to help care for folks who really need comprehensive and complex care.
If I could add a point of emphasis to what Heather said too, I mean, when you look at the healthcare indices for Indiana and you think long term, there are some disturbing trends in regards to obesity, smoking, diabetes that begins now in adolescence. So we have a whole generation that, unless we start to make some changes in that behavior and that structure, we're talking about a return on investment that's going to be very, very good in the long term.
Heather, let me ask you about the legal piece since you work for the McKinney School of Law. This is, of course, one of the states that signed on to challenge the healthcare law before the Supreme Court. The Supreme Court broadly ruled in favor of the federal government earlier this year. Are there still legal challenges, do you think, out there that could potentially get in the way of states going forward with implementation of this law? Are there other ways you see that someone is going to say, wait, here's another point that we haven't discussed yet?
You know, never say never. But I think at this point, it is fair to say, even if there were legal challenges brought, there will be things that need to be implemented before the legal challenges would make its way through the court system. So at this point, I think it would behoove any state, particularly as we're looking at Indiana, to assume that we're moving forward. Because if we wait any longer, we may lose the opportunity for Indiana to really have our own system that responds to Indiana specifically. Again, as I said with the exchange, just because we don't do it this year, that doesn't mean that in future years we lose the opportunity to apply for a state-run exchange. But but we have some unique needs in this state. As you were saying about some of the indicators, we now have a generation of children who may for the first time have a life expectancy that's shorter than that of their parents because of obesity. We need to do something about that, in my opinion. And Indiana has an opportunity here to really look at their system and see what are we going to do for the state.
Mark and Nancy, let me ask you, are there things about the Affordable Care Act that do not benefit the state, even if it's implemented by the federal government? Are there things that you would change that you think are not necessarily beneficial to the specific constituencies that the two of you serve?
I don't see anything in there that I would change.
My general constructive criticism is way too much regulation. I mean, we know the act itself is, I think, 1,000 pages or something, and for every page of law, there's another 100 pages of regulation. And so that's not unique to Indiana, by the way. That's across the country with the federal government, but we're drowning under the regulatory issues here in terms of trying to comply. So,
which regulations are you talking about specifically?
Well, any aspect of this law will have significant regulation behind it in terms of the details, from the administration of the law to the billing of the law to the auditing of the law, et cetera. And all of that adds tremendous cost.
An example of that would be the essential benefits package. So the Affordable Care Act itself said there will be an essential benefits package that any insurance policy that's issued under this has to meet. Well, then it had to go to the Department of Health and Human Services for Health and Human Services to actually define what that essential benefit package was. That is only one of many of those types of issues that had to go both through the legislative process to become the Affordable Care Act, but then gets passed on to the administrative process under the agencies. Go ahead.
Also, changes in the system infrastructure is in there. And what does that mean, and how is it going to be regulated? So yeah, there are regulations in there that's going to cost money.
Yeah, we're going to have to find out how all those things go. You know, it was the act that Nancy Pelosi famously said was so big we had to pass it to read it. So thanks to the three of you for being here. It's a complex discussion, but I'm glad you've helped us understand it a little better this evening, and I'm sorry we only had half an hour to do it. So thanks also to all of you who watched and listened. Please send us your questions for next month's In Focus program. That email address is infocus@indiana.edu. You can leave a comment. You can see the full video of this show at our website, indianapublicmedia.org/infocus. Have a nice evening.
Production support for this episode of In Focus is provided by Hoosier Energy, providing electricity to Central and Southern Indiana electric cooperatives and their member customers. Information at HEPN.com. And by WTIU members. Thank you.